There are still people coming in, but I guess Silu will allow them to enter as they come. Welcome, everybody. My name is Petri Myllymäki. I'm a professor of AI and machine learning at the University of Helsinki, and I'm also vice director of the Finnish Center for Artificial Intelligence. And to you all to note that this webinar will be recorded. The recording is already on. And we are having a series of webinars on AI and data against COVID-19. This is organized by the Finnish Center for AI and the Helsinki Centre for Data Science. And today is the first edition of this webinar series, and we have two talks. And the first talk is by Mika Koskinen, and the second talk is by Antti Honkela. So we would hope to make this an interactive webinar. So if you have questions, first of all, please keep your system muted during the presentations. After the presentation, we will take questions. You can either put them in the chat, or then we will allow you to unmute yourself. And when you are talking, it would be probably a good idea to try to show your video as well if your bandwidth allows. So I guess we can go for the presentations now. And I will put Mika's presentation on, and Mika, the floor is yours.
Thank you. Thank you very much for invitation. I'm honored to give a speech here and give a glimpse of COVID-19 research in HUS University Hospital and in Helsinki Biobank. So the first slide, please. So what is the goal of COVID-19 research? We all know that COVID-19 is a pandemic, and it's really hitting hard all over the world. And for healthcare and scientific community, the situation is quite untypical because the disease itself is new and still poorly understood. But the infection still is serious and can be lethal, so urgent action is required. So we are in a situation right now where we don't understand our enemy very well, but still there is high urgency to act and to act wisely. So the key research questions are very, very practical. How to allocate limited healthcare resources. For example, there are groups working with computational models to predict the needed intensive care capacity. And we need to identify risk factors of severe forms of the disease. And using the knowledge of these risk factors, we need to identify the most vulnerable people groups. And later on, when vaccination will be available, we use this information to prioritize the vaccination to those most vulnerable groups. So we are working currently to identify factors that could protect from severe forms of the disease. For example, we look for medications and treatments in certain patient groups and severity of COVID-19. And to identify these factors is very important for prevention and for protection of citizens in general and protecting the healthcare workers. And some more scientific research questions relate to deeper understanding of the disease progression and of course the background, the etiology of the disease. And finally, after the virus infection, we try to determine the immunity-related questions, like how long does this immunity last? Next slide, please. So what is the role of data repositories? So electronic health records contain lots of current and historical data about patient state, like earlier diagnosis, medication, treatments, and laboratory values. And everything is time-stamped. In HUS, we have very large data repository, and we call it HUS Data Lake, that integrates data from a large number of smaller databases. And this makes data much more easily to search and to query. So HUS Data Lake contains practically all patient data of HUS since 2007. But of course, there are some exceptions. So in COVID-19, we need to identify risk factors of severe forms of disease, identify vulnerable people groups, find protecting factors and drugs, and understand disease progression. And this kind of retrospective real-world data, like we have, is a central element here. As clinical data is acquired in everyday healthcare practice, it may not be enough for biomedical research itself. But in Helsinki Biobank, which is a part of HUS, we have biological tissue samples and blood. And from these samples, we can analyze more biological data. So, and Helsinki Biobank also has the genomic data already from tens of thousands of patients, and these numbers are constantly rising. The genome data comes mostly from large FinnGen study. And in hospital environment, we have a great opportunity to link genomic and clinical data. And more, through Biobank, there is an opportunity to return important health-related information to patients or call selected patients to participate in a new research related, for example, to a new drug. So biobanking is based on volunteers and patient consents, and I hope you will all visit our website helsingibiopankki.fi. And in Finland, we have many governmental registries, but from my own perspective, the most useful ones are Kela, Register of Purchased Prescription Drugs, drugs bought from pharmacies. So Kela is a social insurance institution of Finland. Also THL, which is a National Institute for Health and Welfare, is governmental agency, and they collect data from diagnosis, treatments, and hospital visits from public sector. And these registries are called Hilmo and Avo-Hilmo. THL also maintain the National Registry of Infectious Diseases, which is important for COVID-19 research. And these all register link by personal identification code or social security code that is unique for each citizen. And we have learned that this kind of unique identity coding is not so common globally, which certainly is an advantage for us. So the use of HUS and governmental registries are heavily regulated by several laws. Recently, a new agency called FinData started. And this FinData can grant permissions to combine data from different institutions, but In HUS, where we are a register keeper, we can give permissions to HUS data. But in any case, the research data is always anonymized and curated by HUS officials. A little bit comparisons. So HUS is a tertiary healthcare provider in Uusimaa district. And our database contains very deep and very detailed information about patients' health, but we don't have much primary care data that different cities have. So Hilmo THL registries, they do contain data from different cities, towns, and from public sector. But this Hilmo data may not be as deep and wide as our data in HUS. And we have also data of drugs prescribed and administered in the hospital, but we don't have a full picture how prescribed drugs are used. So for this purpose, the Kela drug purchase registry gives a watertight status of how patients use their drugs. And finally, before I show a couple of examples, I should say that real-world data is primarily intended for care of individual patients and for manual use by healthcare personnel. So repurposing such data for business intelligence or scientific applications is not trivial and typically requires quite some effort. So the complexity of databases are also underappreciated, and there are missing pieces of data from scientific point of view, and only a part of the data is structured and much is written in freely text form. But people are working hard in HUS to bring the data into easily manageable form. So please, next slide. Here are some examples of clinical data. So clinical data is the key to understand the disease course. Here are 2 laboratory tests from HUS lab, CRP and lymphocytes. CRP describes level of inflammation, and lymphocytes are white blood cells that participate in immune response. The x-axis is days from SARS-CoV-2 test, and there the blue color at the bottom are people with mild symptoms. The orange curve present people that were hospitalized, and the green line are people in intensive care, and the red line at the top are those who died. And these lines are median values over population at with respect to day. So the laboratory results provide information of patient state and prognosis, and open possibilities for systemic modeling of patient state. And there are also slight indications that some laboratory tests could predict outcome even before hospitalization and before COVID-19 testing, so prior to day 0. So next slide, please. So hydroxychloroquine is one drug that has been on news recently, but whose effect is not proven, or randomized controlled trials, they have not been done. Still, there are prescriptions have skyrocketed recently in many countries, and after Donald Trump advertised it. So hydroxychloroquine is commonly used in Finland for reuma. In HUS we have a rheumatology quality register, and we decided to look whether it has whether this drug has any effect on COVID infection. So we analyzed medical records of 170 70 patients and looked if hydroxychloroquine users different from other rheumatology patients in getting the COVID-19. So, but we did not find any evidence, and we wrote a paper about this result. So at the times like this, even showing statistically insignificant results may affect how patients are treated all over the world. So we did this in a group of researchers from HUS, including our Chief Executive Officer Juha Tuominen, with Visa Honkanen and Taneli Raivian, and other data analysts from Terveystalo. Next slide, please. Here is data from hospital visits related to myocardial infarction on the left and on brain ischemic attack on the right. And we can see the monthly variation in both figures, but this spring 2020 numbers radically drop. The number of diagnoses and the number of analyzed troponin tests done for infarct patients, troponin on bottom left. This indicates that the number of infarctions have radically dropped this spring. So similar trend is seen with brain ischemic attack. And this is a very strange, because infarction is very painful, and patients just would not leave at home with that kind of pain. So the reason why these numbers have dropped so dramatically is one issue that we are studying with Professor Juha Sinisalo. And in this study, we include some other data modalities such as air pollution time series and data from infectious disease register, and even some mobility movement data from Telia cellular network operator. Next slide, please. So there are some public information about COVID-19 studies in Helsinki Biobank, and very briefly I go through it. The first one relates to screening the influencing factors on the course of COVID-19 infection using clinical and genomic data. The second study covers antibodies of the virus and the relationship between hereditary factors and the severity of symptoms. And the third study illustrates the relation between genetic factors in the individual variation in the course of coronavirus infection. So next slide, please. So finally, I would be glad if you visit our website, helsinginbiopankki.fi, and would give your permission for biobank research. These images are from our current campaign in television, radio, and elsewhere to find biobank volunteers. Okay, thank you for attention, and if you have any questions, I would be happy to answer.
Thank you, Mika. I will now switch to the presentation slide that I forgot to show, that Mika's affiliation is shown. So now if anybody would like to ask Mika something, raise your hand in the Zoom, and then we will give the floor to you, or write something in the chat. Okay, there's Patrick, do you want to ask your question on live? Can you unmute yourself?
Yes, I unmuted myself. So, so thank you for the interesting talk. It was really interesting about the drop in heart attacks and this thing. I just have a very detailed question, because you were praising so much this Kela registry of drug use. But to my understanding, it doesn't include everything. It's so that it's only those for which they have done payments. So there are medicines for which you don't get any payment from Kela. Would it be possible to get the data from Kanta, or is it somehow so that it's not allowed to get from Kanta?
I should say that that is a question that I am not quite right person to answer. Kanta might be the case that they don't give out data, but at least from I don't know if they have given out any data. But Kela registry is for purchased prescribed drugs that are given out by the pharmacists at the counter, and of course that is not even all the data. For example, we in HUS we have in-house given data, given medicine. We can give some shots, we can give some treatments, therapies, and those data. That data is only in our house inside, like in oncology treatments and stuff.
Oh yeah, of course, that was a good point. Also in elderly care homes and so on, where drugs are administered by the personnel. Of course, yeah. Thanks. That's of course a big difference from all the drugs that are used. Okay.
Thank you, Patrick. And then we have a question from Pasi Malmi. Pasi, do you want to ask your question yourself?
Well, hello. So I'm curious to know if there are any blood samples that have been analyzed from point of view of vitamin D deficiency in your data.
I think we have not done that.
Because some theory, it's a hypothesis, and Iceland actually gave a recommendation that people should increase their vitamin D, but that's the only country that I know that has increased the recommendations because of COVID-19.
I think we, in Helsinki Biobank, I think we don't have such research going on.
Okay.
But we have certainly blood samples where researchers could do something like that.
Okay, thanks.
Okay, thank you. Are there any more questions or comments? Well, maybe we then thank Mika for now and move
Patrick,
on. Yeah.
Patrick, there's another question in the chat.
Oh, yeah. Nitin Shoni, do you want to unmute yourself?
Yes. Thank you very much for this presentation. I had two questions. One was about the nature of interoperability standards that are being used to allow this data to be shared easily among repositories, especially if you want to conduct analysis between the phenomic and genetic kinds of data, which is not always easy. So maybe you can comment on that. And the second part, I was very surprised and curious to hear about how user mobility data is being used for such research. Since I'm new to Finland, I'm not familiar with the research protocols and how you allow user consent for that kind of analysis.
Okay, thank you for the question. So there are standards of if you mean the data formats and stuff.
Right.
There are some standards like OMOP or something like that that we could. There are some experience in the hospital how to transform the data into certain formats, but as a raw, the raw data is not in any that kind of format. But we have projects where we collect and transform the data into particular formats. I think that is not a problem. And the second question was mobility data. So this mobility data that I mentioned about, it comes from Telia, which is a commercial operator, and the data is as aggregate data. It comes as aggregate data, and we have so there is not any kind of identity information left, and this data describes how people move between areas or between cities in Finland. There are some rules how to transform this data from raw, like with the raw form is that cellular phones are connected to certain towers while you move, and the people in Telia, they transform this data and aggregated data across Uusimaa district. So we will not have any kind of personalized data, but that is aggregate data that describes the population behavior.
Thank you. That answers my question.
Okay, thank you. And then we have a question from Andang. Go ahead, please.
Hello.
Hello.
My question is, like for example, another country that they use another analysis system to, like for example, if they got one positive pattern, and they will analyze that pattern is F1, F0, or not, and then they analyze who can be the F2, F3, F4. They use this situation and to make tests for them a lot in many countries. Do you think that if Finland use this situation, it will affect to GDPR privacy laws in EU and in Finland or not?
I am sorry, I don't completely understand the questions of F0 and F1.
For example, that in the EU and in Finland, that they have the laws for privacy, GDPR, for any kind of field, and in clinical hospital too. So, but if in hospital they analyze and they choose that pattern, that okay, this pattern is F0. So another people contact to them can be the next pattern will be F2, F3, F4. But to do that, they will need to collect all information that who that pattern are close and contact to. So do you think that Finland can use this kind of solution like another country or not? Because many Asian countries, they use this kind of analyze, and they use personal information of patterns to recognize and to prevent pandemic. Do you think that Finland can use the similar solution or not?
I think I am not a correct person to answer that question. The only thing I can answer here is that what we do is definitely by the book and by GDPR, and we follow that. And in many cases, we have to consult our lawyers, and there are a bunch of laws in Finland that outline what we can do and what we cannot do. That is what I can answer in this situation. Thank you very much.
Thank you for your answer.
Okay, I guess we can now move on, and maybe there will be something related to this question in the next talk that will be given by Antti Honkela, who is an associate professor at University of Helsinki and coordinating professor of a research program in privacy preserving and secure AI at FCAI. So Antti, please, you can take over, and the floor is yours.
Okay, thanks. So, thanks a lot for the opportunity to present our work. And so I'll be taking a slightly different view of maybe focusing more on those people who have not yet been taken to the hospital because of acquiring this infection. And so I'll be talking about privacy preserving collection of contact statistics from contact tracing apps in order to help manage the epidemic or pandemic. And this is joint work with Tejas Kulkarni from Aalto University. And so we're both at the Finnish Center for AI. So, but to understand the big picture, let's start with zooming out and a cartoon model of an epidemic and how we can model the progress of an epidemic. So the basic starting point for a mathematical model of an epidemic is that we divide the population in question to a number of classes or boxes. In the beginning, most people are susceptible, so they have not yet been exposed to the epidemic, and they have not acquired an infection either, or an immunity, sorry. After they become exposed by being in contact with someone who's infectious, they move to this next stage, which is called exposed, where they don't infect people yet themselves, but they will eventually develop the disease, possibly with or without symptoms. And then in this simplified model that I'm in, the people are infectious for a while. After that, they recover, or if things go bad, they may also end up dying for the infection. And the model of infections, the spread of the infection here is that when someone who is susceptible has sufficiently strong contact with an infectious person, then there's a chance that the infection will be transmitted from the infectious person to the susceptible one. And in terms of modeling, the key number that's repeated all the time is this reproductive number, usually slightly misrepresented as being this R0, which would represent the reproductive number in a naive population, and more that's one that's sort of a constant. But what's instead, people usually talk about this effective reproductive number, which is one that's applicable to the current state of the epidemic, taking into account the different interventions that are being put in place. And this roughly measures the ratio of new infections over recoveries. And with this model, we can build this into a mathematical model. So here's one simple simulation of how this could look like, that we start with a population that's mainly susceptible. I started the simulation with a very small infectious population, so it takes quite a long time before something visible happens. But then eventually we have this very strong peak. It's basically exponential growth here all the time, but because it starts so low, it will take a long time to reach its peak. And eventually it will die out when most of the population have gone through the infection. But not everyone will eventually get it. So this fact that it's enough that some part of it has the infection is this famous herd immunity, and then that's now being debated when we will get there. Now, in order to model this, basically what people do is to take a mathematical model like this, And then they try to fit a curve like the one I showed on the previous slide to the observed count of confirmed cases or hospitalizations or deaths. So you can add more boxes to separate out the more serious cases that end up being taken to the hospital. But the challenge here is this estimation delay, because we only collect data from these final stages of the process. If there is some change in the rate of new infections, it will take a week or two before we start seeing a change in the number of new positive tests, and especially in the hospitalizations and deaths. So that's the potential challenge for monitoring the situation. But this is very important, because in real life, we can write a mathematical model where sort of the rate of the evolution of the epidemic is constant, but that certainly doesn't reflect reality, because we all know that all these interventions that have been made, social distancing, closures of businesses and everything, have changed the way the epidemic progresses. And so quickly about how to manage the epidemic. Clearly, the aim is to limit the contacts between the susceptible and infectious individuals. And you can do that either via this blanket approach, like social distancing, to limit all contacts, or alternatively, you can try to isolate these exposed individuals through procedures like contact tracing. And with that, you can hopefully quarantine them so that they won't be out there being infectious and infecting everyone else. So how to do this more targeted approach? There's also this classical contact tracing, which does work remarkably well. And I think that's probably a big reason why in most parts of Finland, there hasn't been these outbreaks where kind of people are in the wild, but it's mainly constrained to the Uusimaa region. But the downside is that it's quite labor intensive. And one of the new trends is that people are developing these mobile apps to assist this contact tracing. For these apps, from a European perspective, privacy is considered very important. And therefore, the typical mode of operation, there are several protocols for that. So the original, it started from this collaboration of mainly Swiss computer science experts called DP3T, but the same model has been adopted by Google and Apple in their proposed system. So these are based on a model where no location data from user devices is gathered. This is because location data, such as GPS data, is typically too inaccurate to be really useful in determining who is actually very close enough in order to transmit the infection. And it's very hard to use that kind of data to in a manner that supports privacy. So therefore, the approach to use instead is to use short-range radio in the mobile devices that's using Bluetooth, and they broadcast and record random identifiers from nearby devices, and then by recording the strength of the signal, they can determine how close this particular device has been and how long is the exposure. And based on this, you can estimate what's the probability of exposure at that time. In order to preserve privacy, these identifiers that are broadcast change quite frequently, something like roughly every half an hour. And also to preserve privacy, the only data sharing in the basic model occurs when someone is diagnosed positive, at which point they share the list of recorded contacts, who can then check and get a notification that, okay, I've been exposed, maybe I should go and get tested, or at least self-isolate myself for a while. There's still ongoing discussions on the exact mode, how this would be implemented, basically depending on whether it's the user devices that generate these identifiers, in which case no one else would know, or if there's a centralized database of these identifiers. The former would obviously be much better for privacy, but then there's the downside that the users themselves have to submit for testing after they become exposed. So there's no centralized authority who can approach them. So what does this mean for our model, and how would this be applicable in theory? So for contact tracing in general, let's assume that we are just looking at the effect of these apps, and assuming half of the population start using the app. And so this means basically that we will be detecting 25% of all possible likely contacts between the susceptible and infectious people on average. And if we further assume that all exposed individuals are perfectly quarantined and detected, then we can get a 25% reduction in the rate of potential future infections. So very roughly, this would mean that we could reduce this effective reproductive number from something like 1.2 to 0.9, which is a difference from a growing epidemic to one that's decreasing. Now, if we increase the number of expected number of uptake, we would need a bit over 70% of users to get a 50% efficiency, again, assuming that all of these detected exposures are perfectly quarantined. But now this would make a much more significant reduction in the effective reproductive number, and effectively allow decreasing the other interventions that are in place. But how could we do this? So the opportunity that I see here is to go beyond this, which is that the contact tracing apps collect a lot of very interesting data of close contacts in the population, data that would be very hard to gather in any other way. And this kind of, in the contact tracing, it's difficult because we want to have the specific individuals know who has been in touch. But for the modeling, it would be enough to collect statistical information on the contact frequencies. And therefore, we could see how people change their behavior over time, or if, say, some of the interventions have relaxed, how that affects people's behavior. Like I said, with anything to do with the apps, it's very important to be very strict with privacy. The statistical information that's being discussed here is not quite as sensitive as individual details of who you've been in touch, but still needs strong privacy protection. One further benefit of this is that in order to get significant utility from the sort of basic contact tracing from the app, we need a lot of users to use the app. But here, with this kind of statistical information, even much fewer users would still yield usable data, because now we only need to have one side of the contact. We don't really need both of them. And we can also more easily correct for the undersampling if there's a smaller rate of users in the population. But how can we collect such sensitive data? One approach that has been used by social scientists since 1960s is called a protocol called randomized response, where respondents are instructed to answer a potentially sensitive query. In this case, it might be, were you in contact with more than 10 individuals yesterday? So they should do as follows. First, they flip a coin in secret, and then, depending on the outcome, they either answer truthfully or then flip a second coin and answer whatever the second coin shows. This effectively gives everyone plausible deniability. Even if you say yes, you can always say that, well, it was just the coins. So you can't tell for sure whether someone really would have answered yes. But then if we collect these data from a large population, we can compensate for these random responses and quite accurately estimate the fraction of the population who would really have answered yes. So effectively what we have here is a probabilistic loss of privacy. If you answer yes, then it's more likely that your true answer was yes, but no one can ever tell that for sure. This kind of idea underlies a model of privacy called differential privacy that's nowadays used quite a lot in machine learning and distributed computing data collection in many ways. And it was first formalized by Cynthia Dwork and colleagues in 2006. And the idea there is that we basically require that if we have two different data sets differing by the contribution of a single individual, then it should be roughly equally likely to get any given outcome from the algorithm that satisfies this property. This provides a very strong privacy protection also against adversaries with some side information, has nice theoretical properties like degrading gracefully under repeated use, and being invariant to post-processing. So the technical thing we could do here is to use a variant of differential privacy called local differential privacy to collect these population histogram of number of contacts. And the security model here is that the data are anonymized before they leave the user device. So the user doesn't really have to trust anyone else. No one else can see the data except the user themselves. And the privacy guarantee is such that even if you see a user's report knowing it came from that specific user, you can only guess what that user answered. Well, you have some information from that, but can never know for sure with too high confidence. One potential challenge here is that the rapidly changing identifiers make collection of the daily statistics difficult, because you can't tell if you see sort of a slow trickle of contacts, whether that's one person you've been in touch with all day, that's just changing their identifier, or if you're seeing a new person every half an hour. But I believe this could be overcome, for instance, by collecting the maximum number of contacts over a half an hour period. And then making use of this invariance post-processing, we can take the observed data, feed it to a Bayesian probabilistic model, integrating data over multiple times and integrating other data we have, and then we can produce a sort of real-time model of how these behavior changes and effects change the evolution of the epidemic. So just to show graphically, the data we had previously focuses a lot towards the later stages of the development of the epidemic for an individual. So with this, we could get a glimpse on what happens at the very early stage. A few more words about the privacy. So there's one caveat is that if we repeat this data collection over time, the theoretical privacy guarantees we get will degrade over repeated data collection. This is partly mitigated here because the users would only be reporting new data every day. So it's not as susceptible to the sort of repeated analysis risks, so which would be basically that in the if you were to repeat the randomized response query several times, then you could start combining responses from a single individual to make increasingly strong inferences of what their true response was. Here that doesn't apply quite as well because sort of all the reports are different, but still theoretically there's a risk. So some kind of ethical review of costs versus benefits would be needed. There's also a technical solution for this, which is requires a bit more infrastructure, which is to use so-called secure shuffling. So for instance, submitting the data via Tor network or some mechanism where you can't associate the reports to any individual, then we get a much stronger privacy guarantee. And basically, there's no concern even after repeated collection. One thing to note here is that if we go this way, so even if someone could break this, the security of this shuffler, even then the base privacy guarantee would hold. So we really have a quite strong privacy guarantee here. So how would this work in practice? So here's some simulations showing as a function of the level of the privacy guarantee, with the level 1.1 here referring to the level you got from the coin flips, for a simulated population of 1 million individuals, trying to estimate their the average number of contacts when we have a fairly heavy tail distribution of contacts with a true mean of 2. And as you can see, we get fairly accurate estimates even from a single collection. And of course, if we repeat this over a number of days, then we sort of get an even more accurate picture of how this would evolve. With that, I conclude. So basically, it's been now like, I guess, 2 months for most of us, but still in the big scheme, the COVID pandemic has just started. So I guess the most recent reports were that, I mean, the people in Finland who would have immunity towards the virus would be most likely in single-digit percentages. So there's a long way before we get to herd immunity. So more likely route out is the vaccine, but yeah, depending on who you listen to, that might take quite a long time to develop. So in order to help smooth our way there, I believe that collection of these daily contact statistics from the contact tracing apps, once they are deployed, could provide a more timely data gathering measure that would help us make more timely decisions of when we need to apply additional restrictions. And the approach using differential privacy provides the means to collect these data under strong privacy guarantees to the users of the app. With that, I'd like to thank you all for your attention, and I'm happy to take your questions.
Thank you, Antti. So there's a question from Iris Määttä. Please go ahead.
Sorry, I was in the chat function. I would just ask if HiDATA is involved in developing Finland's contact tracing app.
So I have been obviously talking about this with the people developing the Finland's contact tracing app, and the aim would be to incorporate this kind of functionality, but yeah, no, not very practical news about that yet.
And then Pasi Malmi, go ahead, please.
So just what other prevention measures except this tracking did you use in your model? Did you, for example, speculate about face masks or that kind of things?
I haven't been doing any such modeling, so so I guess, I mean, the model that I had there was just for the data collection, and yeah, then it was more like a cartoon of how these simple epidemic models would work. But yeah, wasn't meant to be a thorough model for that.
Okay, thanks.
Okay, are there still more questions or comments? Nitin, go ahead. Nitin Shoni, please go ahead.
Yeah, sorry, it was a very quick question about contact tracing, because it all assumes everybody uses a mobile phone, and there are many sections of population like children and elderly who may not be savvy enough to use these apps or have Bluetooth functioning. So how do we deal with these other populations to allow contact tracing without mobile phone data?
I guess, I mean, this would be complementary to the traditional contact tracing. And yeah, I don't think anyone assumes that all people would start using that and then that would replace it. Rather, I see it as something that complements it. And I would imagine it would be especially helpful in things like if we start using public transport and you're in a busy metro or a train, you're not going to ask the names of the people who happen to be in the same carriage as you were. But then with the app, you could potentially get a record of those. So more like complementing that.
Thank you.
And then next, Patrick Florén has a question. Go.
Yeah, I would like to continue a little bit on this because I think there is the problem of communication. So when about the possibility of this app that it's revealing information about them, I think this privacy preserving methods that you are telling about here could be somehow used to convince people that it's not dangerous to use the app if it is so that the app will use these kinds of measures. But I think this concept of differential privacy is maybe too difficult for the man on the street to understand. So how should one go forward to convince people to use the app?
Yeah, I guess that's a good question. Well, maybe, I don't know, is the coin flipping too difficult for the man on the street to understand? I mean, that's essentially what it's doing, especially in this particular case. But yes, for the contact tracing app, I guess, I mean, there's there's the traditional mode that's for contact tracing that would have a sort of very different model of how the privacy works, because you are really sharing identifiers that can be linked back to individuals who you were in contact with. The mode of operation that I'm proposing here is actually quite orthogonal, because we are only sharing essentially anonymous aggregate data. But yeah, whether it's worth it doing the app just for that, probably not. So it's more like something that could piggyback the original development if that gets deployed and being in use. Yeah, but communicating that, I guess it's challenging. A lot of that, I guess, comes down to trust. So if there are experts that explain it to the best they can and people trust those experts, then maybe they start using it.
Okay, I think it's time to start to wrap up. I think this was a good start for these seminar series. We are going to have these events every Monday, every 2 weeks. So the next one will be on the May 25th, but at 2 o'clock, not 3 o'clock like today. And the next one on June 8th at 3 o'clock again. And as you can see, like as we hoped, we would like to show that obviously in this pandemic, the people in the focus are people working in medicine, epidemiology, and healthcare. But people working on data and AI can also contribute to this important phenomenon. So we are doing our share. Next time on Monday 25th, we have two speakers. One is Alexander Turnroot from Finnish AI Accelerator, and then we have a speaker from Indoor Atlas. I believe they have been working this same topic as Antti was talking about. I would like to thank a lot our speakers, our organizers, and everybody who attended. Hilu or Simo or anybody, did I forget to say something important before we stop the show?
I guess you didn't miss anything. So indeed, I will be chairing. This is Simo Sarkka. So I will be chairing the next session, which is indeed 25th at 14, 2 o'clock. And yes, so indeed, so the other speaker will be Otto Seiskari, who is indeed going to discuss contact tracing apps and indoor positioning. And then, so we will have these 2 webinars at least, but we are also considering to have one more, 4th one after that, but we can come back to that later.
Yes, I believe we were over 60 already in this first event, so I would like to thank all the participants, and maybe we check out for today. Thank you, stay healthy and have a nice day.